Right, this is the remainder of the cholelithiasis gallbladder discussion that we had today. In some patients who are not candidates for cholecystectomy, maybe they have an inoperable cancer or obstruction that they're unable to operate on, they can actually put something in known as a transhepatic biliary catheter. Sometimes we're going to know it as a Billy catheter. A little similar to a T-tube, but the indications are different and it looks different. Okay, so the way it's inserted, the drainage bag and the exit site might look a little similar to a T-tube, but it's going to stay in longer than a T-tube. So most often these patients are going to be discharged home with it. And again, same indications, right, to drain the bile, to make sure that we don't have any increasing risks of an obstruction with increase in our risk for cholangitis, inflammation, infection of the common bile duct. So things that we're going to do for these patients if they have a transhepatic biliary catheter or Billy cath, or things we're going to teach our patients is make sure that the drainage bag is secure. Sometimes they're sutured in, but we just want to make sure that it doesn't pull out or it doesn't fall out. Make sure that you avoid any kind of kinking of the tubing. We want to make sure that it's patent and open. And we're going to make sure that we maintain good intake output, especially output, because we want to make sure that the catheter stays patent. Remember, meticulous skin care because Billy or bile is very irritating and excoriating to the skin. So again, in our patients who are at risk for gallstones, cholecystitis, looking at some of those risk factors, obesity, pregnancy, multiple births, are they on hormone replacement therapy, like estrogen, after menopause, oral contraceptives? So there's some genetic component, but we know increased fat, cholesterol intake, sedentary lifestyle, so no exercise. When we're looking at weight loss, anorexia, we might see this in patients who suffer from chronic gallbladder disease where maybe they haven't had their gallbladder removed for whatever reason. If these patients are having a hard time getting that bile out to break down the fat for utilization, they're probably going to have some weight loss, fat intolerance, so indigestion, nausea, and vomiting if they don't have the bile that's readily available to break down the fat for utilization. So we might think chills associated with fever if these patients truly have a cholecystitis or maybe a possible perforation that's led to a peritonitis. So these patients are going to have more of a risk for systemic infection. Cholangitis if the common bile duct becomes inflamed, irritated, infected. And so some of the things that we're looking at if there is a complete obstruction in the common bile duct from a gallstone, clay-colored stools, steatorrhea, dark tea-colored urine, and then pruritus, right? Because the bile salts from the bile are going to start to accumulate under the skin, which is going to lead to a lot of itching, dry skin. So where's our pain? Is it right upper quadrant? Is it more of a colicky pain that's not going to improve with vomiting? Okay, so some other things that we're going to look at in this patient, fever. Jaundice, so that's sclera. Is there jaundice within the sclera, that yellow discoloration? So a lot of times we're going to see some tachypnea, splinting, tachycardia. If the pain in the right upper quadrant is so bad that these patients are actually going to be kind of pulling their breaths because it's so painful that area, every time they take in a breath, is irritated, they might have some tachypnea with shallow breathing. In some instances, the gallbladder may be palpable. So we know guarding and distension may be something that happens with perforation if these patients have peritonitis or cholangitis. But sometimes if the gallbladder is inflamed and enlarged enough, it can lead to guarding and distension. Our patients, if we've got liver involvement, if we've got some inner engagement of the common bile duct, we might start to see elevated serum liver enzymes, AST, ALT, and alkaline phosphatase is also an isoenzyme that's released from the liver when there's an impairment or injury. We might see an rise in our bilirubin level if we've got a common bile duct obstruction. We're going to see increased urobilinogen in our urine. Leukocytosis is common with cholecystitis, and we're also going to see it right with cholangitis, peritonitis. And we said ultrasound is the key diagnostic test. So what are our main nursing diagnoses? Acute pain, imbalanced nutrition, less or more than body requirements, depending on what we're looking at when the patient comes in. More would be our risk factors for cholelithiasis. Risk for infection, right? Risk for bleeding. So our goals for these patients obviously is relief of pain and discomfort. We said we use a lot of morphine. We can use Dilaudid and fentanyl. And we're also going to consider maybe Toradol as an NSAID. Monitoring these patients post-operatively, whether they're having a lap or a traditional cholecystectomy. So making sure they're not having any complications, or at least monitoring them, detecting it early. So like we said, a lap chole, yes, infection, perforation, which they could perf the liver, they could accidentally perf the vena cava or a major artery. So bleeding, infection. So from a health promotion standpoint, who are our patients that are at risk? What's our patient population, and what are our predisposing factors? High fat diet, sedentary person, overweight, maybe a genetic or family predisposition to gallstones. Advancing age, estrogen or oral contraceptives. And then ethnic groups are at a little bit higher risk. So Asian Americans, African Americans, Native Americans. And we talked a little bit about lifestyle alterations. So pain management. We've already talked about some of the pain meds that we're going to use. We're going to start with IV, and then we're going to transition these patients to by mouth. And so we're assessing their effectiveness. What's their goal for pain control? Where do we want them to be on a pain scale? When are we coming back an hour later? Are we using some other things in addition to narcotics? Positioning, non-pharmacologics. And so, of course, if these patients are uncomfortable, they're in bed, we're going to provide other methods of support, emotional, clean bed, linens, like we said, position, upright. Sometimes after these patients are recovering, they like to be in the sideline Sims position. And if these patients are NPO and they've got an NG tube to decompression, are they at risk for dry mouth? So if they're NPO, do we need to be doing some oral care? Managing nausea and vomiting, right? So most often if we take this gallbladder out, they're going to be okay, but we've got to wait to stabilize them before we take them in for surgery. So NPO, NG tube for decompression. So they're probably going to need some IV fluids to keep them hydrated. Antiemetics such as Zofran, Compazine, maybe Phenergan is a last resort. And then accurate measurements of INL. So patients who have pruritus from the accumulation of bile salts under the skin, especially with complete obstructions, we're going to make sure that we do some very gentle baths with them. So we're going to avoid any kind of hot water and any drying soaps that are heavily fragranted, that are pretty harsh to the skin. Maybe some lotions, make sure our linens are soft, clean. Sometimes controlling the temperature of the room helps. Some patients who get really hot, it makes them even more itchy. We don't want them to cause any excoriations or breakdown in the skin, so let's keep their nails short and clean. And if they are going to itch, make sure they're doing it with their knuckles, not their nails. So our outcomes in these patients, again, pain control, pain relief, dietary restrictions, dietary education, and then obviously activity level, whether it's before as a preventative measure with sedentary activity, or if we're talking about activity level after surgery.